to the sentinel lymph node as in staging procedure, and then maybe we do nothing after that. I guess maybe we'll be lucky enough to leave that. So we know why we do need to do something in the axilla. One thing is to remove the disease from there, or at least that's what we thought would be really important, and now this is debatable, and to decide about the adjuvant therapy. So those are the reasons why we insist in doing something in the axilla. The reason we don't want to do it is because there is morbidity. And even though it looks really simple, the lymphedema, it might look not a major issue to us, comparing to a life-saving procedure of surgery and adjuvant therapies and everything. So woman is still alive, so why should we care about the lymphedema? Because now, unfortunately, they live longer than they used to be when we were younger. So they live longer now, and they keep calling us and keep coming back to us about that lymphedema. It's really annoying. So we have to do something about us ourselves to get rid of those patients. Okay, so you know I'm joking, I'm sorry. So there is morbidity with the axillary surgery, we know that, and that's why we try to do less and less. It makes quite a difference. So this is actually what's happening now. The traditional axillary clearance was challenged. We know we're moving away from that now. Sentinel node biopsy is the golden standard, and we are moving towards radiotherapy of the axilla instead of axillary clearance under some specific limitations, of course. Okay, the sentinel lymph node biopsy is the gold standard, we know that. So when we initially diagnose the breast cancer, we have to assess the axilla and decide if there is a possibility of that being metastatic or not. Till now, we were relying too much on clinical examination. We know that the false negative is high, is more than 50%. So the most reliable method nowadays to assess the axilla preoperatively is ultrasound. So this is what we do. When we diagnose the breast cancer, we perform an ultrasound of the axilla, and if there are any pathologically looking nodes, then we perform a core biopsy. Okay, the sentinel lymph node biopsy came back with those trials, we know that, and the techniques we have now in marking the sentinel lymph node biopsy, the sentinel lymph node is the blue dye, okay, the blue color we all know, the radiocolloid, the technetium, the ICG-10, the method you saw yesterday, which is a green color again, that's all, it's just a color. And there are some enhancing techniques, they're working on it, they're not well established yet, but they are happening. It's the microbubbles, contrast-enhanced ultrasound with microbubbles, and the supermagnetic nanocolloid, which are the techniques that are now evolving, and hopefully we're lucky enough to the next IBUS, we will have workshops on those too. Okay, what happens when we have a positive lymph nodes, a positive sentinel lymph node? Do we do an axillary clearance or not? So now this is the question we're now moving towards. We left the sentinel lymph node behind. We know this is what we do now, so we all accept that and we move on. The question is, what do we do when we have a positive sentinel lymph node? So the traditional regimen would be an axillary clearance. What's coming in now, it's radiotherapy of the axilla. So instead of doing the axillary clearance, we are happy to do just radiotherapy. And those trials, actually, they were very well incorporated in NCCN and ASCO guidelines. So most of the centers, they do treat the positive sentinel lymph nodes with just radiotherapy. And there are ongoing trials on that as well. So there are trials that confirmed that if you don't do anything in T1 or T2 breast tumors with up to 3 positive sentinel lymph nodes, then there is no difference in overall survival or disease-free survival. And we're happy with that. So it is axillary clearance versus to just radiotherapy when you have positive sentinel lymph node. And the axillary clearance is starting to get less now. We are happy with level 1 and 2 lymph nodes only. And going up to level 3, if we have some indication that there is something wrong there, or if we feel like we're going to minimize the burden of the cancer cells. But in routine, level 1, level 2, some centers say 15 lymph nodes would be enough, some ask for 18, but level 1 and level 2, usually it is enough during the clearance. The main issue nowadays is the neoadjuvant chemotherapy, exactly what Professor Yanoulis just mentioned before. What happens with when we have pathological lymph nodes, we perform neoadjuvant therapy, what happens after that? So sometimes we have a conversion from positive lymph nodes to negative lymph nodes, considering the ultrasound assessment. And how do we treat that? Do we still perform axillary clearance, or do we move forward on? So the percentage of that conversion has to do with the biology of the tumor. So it is true that for HER2 positive nodes, we have a conversion of about 65%. For triple negative, it's about half of them. And for ER/PR positive, HER2 negative, we just have a 20% more or less of conversion. So how do we treat those patients? Some centers, they just do sentinel lymph node again. There is not enough evidence to support that, but there are ongoing trials. And I guess, okay, my feeling, this is where we should move in the future. For the moment, most of the centers, we still do perform axillary clearance. Is it the same thing for, is anyone working in a center that they do sentinel lymph node biopsy? Okay, yes, okay. I think my personal feeling is that this is the future, so probably we'll do that. Clipping the lymph nodes is another issue which is very helpful. I think it's very useful and will help us decide in the future years, in the recent future, if we need to do anything more than that. Okay, trying to avoid the lymphedema, there are some other methods coming up, just like the axillary reverse mapping. What they do is actually inject radiocolloid to the tumor and then inject blue dye to the arm. So we try to, during the axillary clearance, we try to separate the lymph nodes that are arm only and not breast, so it's safe to leave them behind, but reduce the possibility of lymphedema. So that's the philosophy behind that method, which is, okay, it's a bit tricky. I haven't done it myself. I have no experience on that, but it sounds a bit tricky. And there is a main question concerning the overlapping, what happens with the lymph nodes that are both. So for the moment, this is concerned not safety from oncological perspective, so this is not confirmed, so it's not happening. It's an ongoing trial. But I think it's a bit complicated, so it's really hard to make it a practice. So all the future perspectives concerning the conversion of positive lymph nodes after neoadjuvant chemotherapy are aiming on doing radiotherapy only. And there is also a trial, the MD Anderson trial, that says maybe they do nothing, not even radiotherapy. So all these are ongoing. Probably we'll see some results and maybe we'll change our practice, because I guess the axillary clearance, it is always the issue for surgeons and patients. So what we do now, this is just the NCCN guidelines, but pretty much all the guidelines worldwide have the same philosophy. So in T1, T2 tumors, we just do sentinel lymph node biopsy. If we're planning to do radiotherapy to the breast, so if we have breast conserving therapy, and if there are not too many sentinel lymph nodes involved, up to 3 of them, then we don't need to do axillary clearance. So we do axillary radiotherapy. Of course, unless the patient, of course, is not suitable for sentinel lymph node biopsy, so this cannot happen. And even in some cases that we feel like the tumor is a good tumor, is a strongly favorable tumor, as they say, if the results of an axillary clearance wouldn't change the therapy plan that we already have in mind, in old women where the morbidity is higher, the lymphedema and all the complications are higher, including the shoulder stiffness, or patients who have significant comorbidities and they're not happy to undergo another general anesthesia. So the thing is, if a patient is not suitable for sentinel lymph node biopsy, of course, we still go to axillary clearance. Okay, there are not much. The main thing is, we do sentinel lymph node biopsy, okay? And when the results come back, we have to decide if we're doing axillary clearance or just radiotherapy. I think this is the practice that goes on most of the centers, isn't it? I guess pretty much we all have the same practice. And we look into all those ongoing trials to confirm that radiotherapy alone will do the job. Or in some cases, just like a post-knock, I think, in some cases, some trials try to prove that nothing is needed. Even if you have a sentinel node biopsy, up to 3 positive lymph nodes in your sentinel lymph node biopsy, maybe you don't need to do anything, not even radiotherapy. So I guess where we're moving is have a core biopsy on the sentinel lymph node on time of diagnosis, and maybe then we do nothing at some point. Hope so. Okay, in negative axilla then, the golden start on the sentinel lymph node. The axillary clearance is becoming less and less. Hopefully, the junior breast surgeons will never get trained to that. I think this would be a good thing. So we need to have accurate methods of assessing the axillary lymph nodes before the surgery. So we rely so much on good radiologists, and it makes a difference. You all know that. And now the research is focused on doing less and less in the axilla. So that's the main philosophy of what's going on. That's it pretty much. I'm sorry I didn't enlighten you too much. Maybe next year we have more issues to do, more issues to discuss. So what we try to do is do less harm. Any questions? Yeah?
The reverse mapping of the lymph nodes of the axilla.
Yeah.
Would we inject the dye?
Okay.
Which side?
Yes, they do it around the carpal, intradermally again, anywhere. In some centers, they just do it up close to the axilla. But I don't know, I have no experience on that. I haven't even seen it, so I can't tell you anything. So we're just into the literature. It sounds interesting, it sounds funny, but it sounds hard. Yes? Do you have? Yes, please enlighten us. Between the digits. Okay.
But the study did not show any benefit to reducing edema. And at the end, oncology comes first, even if we see that the lymph node
Yes.
belongs to the arm, we still
So I guess your feeling is that it's not going to happen. It's very complicated anyway. I mean, in performing is... Okay. But what happens with the overlapping? That's the other thing. But then at the end, would it make any difference in comorbidity? Yes, okay. So probably it's not happening, I guess. Yes. Okay. Yes?
In the neoadjuvant setting, in the NCCN guidelines since 2016, there is also targeted axillary clearance.
Yes, yes.
Or TAD.
Yes, yes, that's true. I think Professor Giannoulis mentioned that, didn't he, with the clipped notes and everything. So yes, that's another ongoing practice, yes. Okay, well, thank you very much. I think I will go on with the male breast because we males, we feel a bit neglected in those courses.